Welcome to Mexico. Today we're going to talk about Mexico's healthcare system. We're going to talk about the present healthcare system, the development, the historical roots, the future healthcare system, the concerns, and barriers and future goals for the healthcare system.
Historic roots of the healthcare system and influencing factors. By examining Mexico's history, we can get a better sense of how the current healthcare system came to be. It began after Mexico's successful revolt in 1877 when dictator Porfirio Diaz took control of Mexico until 1911. During this time, Mexico underwent tremendous commercial and economic growth based on foreign investment in the country. The Diaz government largely benefited Mexico's upper class but failed to include its poor majority. At this time, Mexico's economic system breeds growing discontent, which led to a revolution. In 1910, Francisco Madero, a member of Mexico's liberal educated class who had opposed Diaz over the years of presidential elections, led the popular revolution. On November 20th, 1910, the Mexican Revolution began. After the revolution, there was a merging of the Mexican state. At this time, coverage had been based on employment status. In 1940, Cardenas' more conservative successor, Manuel Avila Camacho, was elected president. The government of Mexico wanted to provide unified care to its people, causing many reforms to the system from the 1940s onward. Between the 1940s and the 1980s, many changes occurred in the system. At this time, healthcare was delivered primarily in hospitals, and costs were increasingly dramatically over the years. Common infections and illnesses were declining, while the incidence of non-communicable diseases and injuries were increasing dramatically. In 1943, the Mexican Social Security Institute, also known as the IMSS, was created to provide healthcare coverage to the private sector. In 1946, Miguel Alemán becomes the first civilian president of Mexico since 1911. Under Alemán's presidency, Mexico undergoes great industrial and economic growth. Adolfo López Mateos was elected president in 1958 and introduced a Social Security Institute known as the Institute of Social Services and Security for Civil Servants, also known as the ISSSTE, which was created in 1959 to provide coverage for government employees and their families. In the mid-1980s, healthcare reform was launched to promote more efficiency in the system by focusing on the uninsured health centers and district hospitals. However, by the 1990s, 50% of the population was paying for health insurance out of pocket and lacked any health insurance. Recognizing this problem, the government prompted to enact reforms in 2003, which established the Social Protection and Health Program. Due to many reforms, Mexico's current healthcare system encompasses both private and public sectors. Non-salaried or formal sector workers are excluded from formal social insurance. The Ministry of Health addressed lack of access to formal social insurance. However, previously these individuals had no coverage at all. Around this time, there were large-scale protests in regards to frustration of the NAFTA system. In all, the system was segmented from the beginning to the reform in 2003. Prior to the 2003 health reform, approximately 40% of the population was covered by the IMSS and 7% by the ISSSTE, and no more than 2 to 3% by private health insurance. The remaining 50% lacked adequate access to public healthcare coverage. Lack of adequate access by almost half of the population led to an increase in out-of-pocket spending for health services, out-of-pocket spending that families could not afford. The government passed the reform in 2003 called Systems for Social Protection and Health, otherwise known as Seguro Popular. Seguro Popular was operational early 2004 with the goal of universal coverage by 2010. In 2006, Felipe Calderon elected president. He addresses issues of poverty and social injustice. Introducing Seguro Popular has reduced the number of people without access to healthcare services in Mexico. It covered more than 90% of the target population by 2011. As Mexico began to provide medical care, the system made use of medical and hospital infrastructure of both the state and the federal ministries of health. And by August of 2012, universal care was established.
Now we will talk about factors influencing system development and the major stakeholders.
Who are the major stakeholders? A stakeholder is defined as any person or party who provides, receives, manages, or pays for healthcare. Therefore, the stakeholders in Mexico include the providers, such as the health professionals, the payers, such as the state and the patients, and employers, such as the state health professionals.
Now we will look at Mexico's mandate, mission, and vision of their healthcare system.
During the 2012 campaign, President Enrique Peña Nieto ran a platform of instituting healthcare reform to establish a truly universal healthcare system that would provide security and stability for all citizens. The National Development Plan and the National Development Plan's program for the health sector, proposed for years 2013 to 2018, was issued in early 2013. These plans emphasized on preventative measures, rather than focusing only on curative medicine. It also ensured that the poorest of the poor gain adequate access to healthcare.
We will look at Mexico's classification of the healthcare system.
Due to many reforms, Mexico's current healthcare system encompasses both private and public sections. 2/3 of hospitals have private beds, while 1/3 of all hospitals are for public use. There are 11.4 hospitals per million people that are publicly owned, and there are 28.6 hospitals per million people that are private for profit. Mexico therefore displays the highest ratio of private to public sector faculties across all OECD countries. Using Boehm's taxonomy, we can classify the healthcare system. Looking at the OECD healthcare system classification, Mexico can be classified under the National Health Insurance Healthcare System, which combines the National Health Service regulatory structures and tax financing with largely private services.
Now let's talk about Mexico's service and delivery of healthcare.
The decisive difference can be found in service provision, which remains for the most part in private hands. First of all, in the NHI countries compared to the NHS countries, private or societal hospitals add up to a larger share, as measured by the number of hospital beds. In all NHI countries, service provision in the outpatient, dental, and pharmaceutical sectors is overwhelmingly in private hands. This can also sometimes be called the social health insurance model, or SHI. The SHI model combines universal coverage with funding coming mainly from contributions and public or private delivery. The system is administered by the public sector, the private sector, or a combination of the both.
Now we will talk about Mexico's regulatory bodies and funding structure.
Since the reform of 1984, the General Health Law regulates all aspects of health and defines the rights for all Mexican citizens. It sets the division of responsibilities for health between the federal government and the states. The aspects of this law have been preserved and reinforced through all reforms that have taken place since its formation. The federal government is responsible for setting legislation, choosing priorities and goals, training staff, and providing technical support for implementing population health programs. State government sets up the local objectives and are responsible for implementing population health programs within their areas. The National Commission for Medical Arbitration, also known as CONAMED, was established in 1996, aimed at resolving conflicts between providers and patients through conciliation and arbitration, and this is the main body for providing protection in Mexico. With CONAMED being the main body of protection, the rest of Mexico's healthcare system is divided into regulatory bodies with coverage based on employment status. All health regulations are created by the General Health Council, also known as the CSG. Ministry of Health, also known as the SSA, is responsible for the regulation and protection against public health risks through its Federal Commission for the Protection Against Public Health Risks, also known as as COFPRIS, created in 2001. Its responsibility is regulating products and services whose consumption may entail health hazards. Health risks covered include those associated with food and drink, medicines, medical equipment, cosmetic products, disinfectants, and any other substances that the population is involuntarily exposed to. As well, the insurance providers within the healthcare system are divided based on employment. The IMSS, or the Mexican Institute for Social Security, covers formal and private sector employees and their families. It aims to provide Social Security and health services at no cost to non-government workers and their families. Public sector employees and their families are covered by the ISSSTE. This regulatory body works to provide healthcare to federal employees and their families at no cost. The State Oil Company, also known as Pemex, the Armed Forces, Sedena, and the Navy, SAMAR, have their own smaller institutions that can also provide health insurance to its employees. Seguro Popular is a public insurance plan that was created in 2003 to provide subsidized public coverage to the 50 million individuals who do not fit in any of the other insurance providers. For citizens to utilize their insurance, they must stick to their specific institutions and pharmacies, with the only exception of going to a different clinic or hospital in obstetrical emergencies. The chart identifies some of these regulatory bodies. Funding structure. Mexico currently spends roughly 6.2% of its budget on healthcare, one of the lowest rates in the OECD, well below the average of 9.6%. Low rate of government spending places greater burden on out-of-pocket, which means roughly 45% of healthcare expenditures are paid for out-of-pocket. Over the last 5 years, the Mexican government has invested more than $5 million in construction, rehabilitation, and outfitting of the medical units, as well as hiring and training medical staff. This is a step in the right direction. However, more investment is required. The capacity of healthcare infrastructure must be increased to provide medical care to low-income populations. Major source of funding comes from federal taxes, with contributions made by states. Families are to prepay a small premium through a means-tested scale to ensure that the public subsidy takes into account family income. The poorest 20% of families are excused from contribution. Financing of health at federal level, or the Ministry of Health, includes a budget that covers resources for public health programs, the Social Protection and Health, Seguro Popular, the IMSS, National Health Insurance Institutes, and any other large hospitals run by the federal government. Financing of health at the state level includes health allocation to the states via FASSA. The amount is determined by the Ministry of Finance and Public Debt under terms established in the Fiscal Coordination Law. States also raise their own revenues via taxation, charges for services, or use of resources. Under current law, the states are responsible for deciding how to spend their resources, meaning the Ministry of Health and the Ministry of Finance have limited authority to address concerns about efficiency or quality. Broad rules regarding how the states can use their health funds, such as no more than 30% can be spent on pharmaceuticals. Greatest weight in funding is given to the as a per capita component rather than needs-based.
Now we will talk about Mexico's healthcare concerns and barriers to service provisions.
Healthcare concerns of the population being served. Mexican citizens face several different types of health concerns that are trying to be addressed. As of right now, non-communicable diseases are the contributing factors leading to premature deaths. The top 10 causes of deaths are diabetes, heart disease, stroke, interpersonal violence, cirrhosis of the liver, COPD, lower respiratory infections, hypertensive heart disease, road injuries, and kidney diseases. Smoking, drugs, and alcohol is also a major factor and a major health concern facing the nation. Are healthcare needs being met? The healthcare concerns of the nation are being partially met. There are definite strides towards social policy implementation, public healthcare system, equitable access, and uniformity in equality of services. However, there is still in the early stages and many inequities and health disparities remain, based on socioeconomic status, employment status, geographical area, gender, and age. In tandem with addressing the inequity to access to care problem, the Ministry of Health also included improvements in quality as part of the policy agenda in the National Health Program 2001 to 2006. More specifically, in 2001, the Mexican government launched the Crusade for Healthcare Equality, whose goal was to provide high-quality care to the population by offering health services in a framework that respects human dignity, autonomy, confidentiality, as well as granting the population the right to choose a physician or the clinic of first contact, to make use of fair general services and health units, to face reasonable wait times for a consultation or intervention, and to have access to the networks of social support during inpatient stays. Barriers and difficulties to service provision. Many barriers still exist to providing Mexicans with the best possible health coverage. They include geographical disparities, downstream approach to care, inequitable access to services, and varying degrees of quality in faculties and medical professionals. Although all these barriers are still present, life expectancy has increased in Mexico to an all-time high of 75 years, and the population exposed to unaffordable healthcare costs has decreased from 3.3% to 0.8% in the last decade. Another effort of the government to deal with the increase in non-communicable diseases was the implementation of the sugar tax. These strides are specifically targeted to Mexico's youth and adolescents. Obesity rates have increased in the adult population dramatically, from 62% in 2000 to 71% in 2012. By implementing the sugar tax and increasing food labeling, the government hopes to work in an upstream manner and prevent future obesity.